center, the brain-abdomen-kidney axis, real-time interaction between ICP, intra-abdominal pressure, and urine output.
Good afternoon. Thank you very much for having me. So I want to present you today what we can do if we measure real-time ICP, IAP, and urine output. Aims are to show you the relationship between ICP and IAP, to show how practical the measurement is, and how we can influence with our treatment outcome of patients. First of all, we need to understand how dangerous IAP can be. In the IRA trial, they collected 490 patients. They measured 3 times a day the intra-abdominal pressure, had a cutoff of 12 millimeters mercury, and correlated the pressure to outcome after 2 weeks, 1 month, and 3 months. What we see already with grade 1, which is mildly elevated pressure, we see an elevated mortality with 25%. If we go to the upper limit of normal pressure, reach 46% already. In this research, they took 5 swine and balloon occluded the abdomen to see what's the influence of abdominal pressure on ICP. We see here, with continuously elevating the IAP, the consecutive following ICP. When we reach 30 millimeter mercury of IAP, we reach similar levels with ICP. As soon as the pressure in the abdomen is released, we see that the ICP goes back to baseline. Subgroup analysis of center TBI and O-center TBI showed us how restrictive we need to be with our fluid balance. We see that if a patient is already slightly positive per day, and we talk here about 400 milliliter, we see higher respiratory failure, more ICU mortality, and more post-ICU mortality. There's a direct correlation of outcome and fluid intake. We see how strict and fine our balance needs to be. If we're slightly positive, we worsen outcome, but the same goes for being too negative. Our study includes patients with EVD or ICP monitor. They have to be at least 18 years of age. We excluded pregnant patients and patients with catheter-related problems. We continuously measure the urine output as well as the IAP. This is automatically measured 2 to 3 times per hour. In addition, we measured the IAP twice daily. We continuously measure the ICP and ventilation parameters. This is the device we use for it, the FICE-QO. This device measures automatically the urine flow down to the milliliter. On the right, you see the transducer. This is directly connected to the catheter and uses pressure changes in the bladder to detect urine, and we can use these pressure changes to detect IAP. What does it mean? We use the patient's urine to measure intra-abdominal pressure. In a perfect world, our patient is in supine position, intubated, ventilated, and muscle relaxated. We install 30 milliliters of liquid into the bladder and then measure in the mid-axillary line. Obviously, our patients are not in that position. We have them head elevated. We don't want to bring them 3 times an hour down to 0, so we need to find a correlation. I show you here 2 patients, and in both patients, we measured the ICP, the IAP on the level of the gold standard in 30 degrees elevation and on the level of the sensor, and compared that to the sensor data. In the first patient, we see the sensor was fixated to the thigh of the patient. With the second patient, the sensor was loose in the bed. The difference is that with the sensor fixated, we have a difference of 4 to 5 millimeter mercury to the gold standard. But if the sensor is in bed and the patient is 30 degrees elevated, we see that we have a difference of neglectable 1-2 millimeter mercury. This is the data we collect. Here we see 1 week in a patient in the beginning of this treatment. We zoom into 1 day, and we go with the different values. You see at 10 o'clock, there's a spike of CSF withdrawal. After that, when you follow the yellow line, you see a decline in ICP. The red line is the IAP, and we see at 2 o'clock in the afternoon a spike, followed by elevated ICP. As soon as the IAP resolves, we see improvement of ICP. What happens at 6 o'clock in the evening? We examine the patient, stop the sedation. So we see ICP goes up, and we also see in blue on the bottom, urine output goes up. Obviously, higher blood pressure, more stress, more urine. After bringing sedation back, everything goes down. At night, we have another peak of IAP, and we see again ICP follows around an hour later. Here we see two measurements to bring it down. We actively treated the IAP and the ICP with CSF withdrawal, and we saw that both pressures go down simultaneously. In this picture, we see an example of a patient with an EVD at a fixed height open. We see all the time that we have a bump in IAP, we have a consecutive bump in more CSF withdrawal. This slide shows basically everything we measure together. Here we have in red on top the mean arterial pressure, the green line is the plateau pressure from our ventilation system, and we see our yellow and red lines with ICP and IAP. In addition, you see the stars on the bottom. A star is the reference for a bolus of furosemide. And we see with the urine output how nicely this patient reacts after furosemide with 200 to 250 milliliters extra urine output. To summarize, automatic measuring is safe, consistent, and sterile. We see that IAP is underestimated and specifically underdetected. I think nobody checks regular IAP in this unit here. Digital urine output management is far superior, and the earlier we see IAP rises, the earlier we can treat, and by that we can reduce mortality and ICP crisis. Thank you very much.
Thank you. Stefan, question at the end. Next talk will be by Dr. Evgeny Karpov from Cambridge. Use of oxygen therapy and management of postoperative pneumocephalus, a systemic review.